myopia and treatment and options on the management and prevention. So Dr. Meenakshi could not be here, and we'll have the first set which will be discussing surgical protocols for phakic IOL practice, refractive implantable lenses. So our first step would be how to manage moderate to high myopia, and the second part would be clinical outcomes of treating myopia or preventing progression by pharmacological and other methods, including 0.01% atropine, which is marketed as myopin by Appaswamy. So we'll start with the first talk, a clinical experience of RIL and toric RIL implantation in 30 eyes by Dr. Ananda Babu.
Yeah. Phakic IOL in myopic patients. How to correct myopia? Spectacles, contact lenses, and LASIK and phakic lens. Phakic lens are used in high myopes, are not fit for LASIK. In the diopter of 18 to 24, phakic IOLs indicated in the age between 18 to 40 who are not having cataract and whose dysfunctional lens index is more than 5. Patients have a stable reflection for at least 1 year. These patients are not happy due to high power glasses and narrow field of vision. Soon after implantation, these patients feel all the difference in the world since they are free from glasses and experience a wider view. Also, visual acuity 1 or 2 lines better than the best corrected visual acuity. Parameters that are taken into account is AC depth more than 2.8 millimeters, iodocorneal angle 30 degrees, and endothelial count more than 2.5 cells per minute, and central corneal thickness more than 400 microns. ACD is taken from endothelium. So depth less than 2.5 millimeters can be a risk factor for ankylosing glaucoma. The white to white is a most accurate method of white to white measurement is digital caliper measured under the operating microscope or loop. So the horizontal visible diameter is 11.89 millimeters. The average white to white is 11.65 to plus or minus 3.36. Corneal diameter less than 10.93 is taken as microcornea, and corneal diameter more than 12.4 is taken as megalocornea. See, exclusion criteria: age less than 18 years, unstable reflection, hyperopia, and posterior cephaloma. See, RIOH do a study here determines the efficacy and safety of the posterior chamber IOL in myopic patients. Study center is RIO, prospective study, 50 eyes, and 6 months duration. Technically, it is a hydrophilic acrylic material, 26% of water content. The RIOL side view, if you take is central thickness 150 to 300 microns, and haptic is 200 microns, and haptic is rounded edge, and the RIL top view, if you take, the convex is facing the top, and there are 4 holes 500 microns thick, and there are specific holes here for spherical, which is 4 holes, and for toric there are only central 2 holes. You can log into company website to get the RIL calculator. And phakic surgery is outpatient surgery which requires less than 30 minutes. IOP25 and 2.6 keratome is entering the AC. Care should be taken not to injure the lens capsule. Please check the movement of the phakic IOL after folding the cartridge. Now the vaulting mechanism is in the superior optic, and the optic should be manipulated only with the blunt clip manipulator. Care should be taken not to fold the haptic under the iris. Visco is aspirated completely. And iridotomy done with the iridotomy scissors, and is so arrival toric 3 cylinder. Instead of marking the axis with the dye, we are using a toric IOL marker. See, once again we can see the IOL which is set into the cartridge, and see the pushing. IOL, so orange line indicates the blood vessels and the marker. White line indicates the 0 to 1 degree, 180 degree, and green line conforms to the axis of the IOL. We can use Pilo to constrict the pupil. Finally, so post-op day 3 we can use, we can see the pictures. See here. So 6%. What is happening? I don't know. One second. It is going. Previously. Yes. So here the postoperative refraction is minus 7 to 10, 30%, 11 to 15 is 47%, and 16 to 20 is 23%, and 22 to 25 is 5%. So anti-chamber depth, so yeah. going like that. See, without even pressing is going. Uh, 3% of patient has 624, 28% had 636, and 45% has 660, and 24% had uh, and preoperative refraction, I've already told you, and anti-chamber measurement is 77.5% had 2.8 to 3.5 millimeters, 22% had angio's depth of 3.5 to 4 millimeters, and post-op intraocular pressure is around 97%, only 3% had less, and preoperative white to white 35% had 11 to 2.5, and 60% had 11 to 12 2.5, and 5% had 1%. And RIL power, if implanted, 50% showed for 10 diopters, and 30% had 10 to 15 diopters, and 20% had 30 to 10 to 23%. So RL consists post-operative vaulting. In the first 3 days, there was 340 microns, and in the end of 1 year, you have 404. So in the central vaulting, if we have anti-segment dosity, we can see the interlens distance between the 404, and if you don't have anti-segment dosity, you can use a slit lamp. A simple examination will show you that there is a distance between the lens. And in left peripheral vaulting, there is distance is 4.4, and right peripheral vaulting there is 5.5 microns. So post-operative examinations at day 3, day 1, and after 1 week, 1 month, and after 3 weeks, out of 50 patients, 2 patients had cyanoid keratopathy, 2 patients had shallow AC during immediate post-op. This prospect study of 50 eyes, 49% had 6.9, 31% had 6.12, and 20% had 6.6. Only 2 patients required, and these are some of the patients. So conclusion, based on the prospective study, on comparison with other studies, phakic corrective procedures are safe and effective for treatment of myopia. It also shows it can provide sharp and clear vision in 96% of our population. It improves 1 or 2 lines more than the best corrected visual acuity. It does not induce dry eye syndrome as in other surgeries. Short-term complications like endothelial damage, ankylosing glaucoma, iritis, anti-capsule injury, lens changes were not incurred during our study. Thank you.
We'll go on to the next talk, which will be by Dr. Sudeep Das. He'll be presenting a specific case study of RIL implanted for a high power myopic patient.
Good afternoon, everybody. Yeah, so it's just one patient. I've used lots of RILs in the sort of a normal power range, but this was a patient who came in with an extremely high myopia. And the problem with extremely high myopia is that whatever they see through the glasses, when we look at them, the eyes look really tiny. And when they look at us or anything through those glasses, everything is very small, and that brings down the uncorrected, sorry, it should be the best corrected visual acuity, the BCVA. And the patients are actually legally blind without glasses. And from the moment they wake up till my daughter doesn't have this extreme high myopia, but she's got a combination of myopia with myopic astigmatism. And I know that, till she wears her glasses and it's right next to her, she almost sees nothing. And of course, the problem with the weight, it keeps sliding down when they sweat, they work, and the vision becomes a lot worse. Prismatic effect is a lot worse with these glasses, and it's very difficult or sometimes impossible to fit contact lenses in these people. And of course, we can't do a corneal procedure on these people. And if we think of doing a clearance extraction, then the chance of getting an RD in these extremely high myopes is very high, because there's so much of vitreous movement following removal of the clear lens. And the advantage with RIL is that there is no distortion or minification, no prismatic effect. Quality vision is the best that they've ever seen, almost from the childhood, and they're so happy after that. And the BCVA is considerably better. Like in this case, it was much more than even 1 or 2 lines. And it's fairly, as you saw in the surgery, it's pretty easily performed, and it's reversible. If there is any problem, patient is not happy, you can always pull it out, not like a LASIK. Chances of RD is not significantly more after this. You're not removing the clear lens. And there is no problem with IOL power calculation when he develops a cataract, unlike LASIK. All this I'll skip because these have been covered in the previous talks. So the normal range that they talk about is 1 to 23 diopters. I have implanted 23 diopters earlier. I never thought I will do this. So this was a 24-year-old male patient, somewhere from the northern part of the country, but he was working in Odisha. He was a painter. His uncorrected visual acuity was only 2/60. And even with glasses, what he was wearing was -18 diopters, was just 636 and N18. And Otteref obviously couldn't pick up anything at all. Intraocular pressure was fine, slit lamp was all right. Dilated fundus, retina, got a retina person to check. So there was a pigmented lattice, but there was no hole. One place there was a pigmented lattice. So again, that rules out CLE. And this is what my people got on retinoscopy, -32. And probably would be accepting something like -33.5. And this is what they got. So with -31, he was 636, -32, he was 6/36 again. And I normally use my lens star for everything, the white to white, the ACD and everything else. This was a time when the lens star was not working. And actually, my VCTs became extremely good at immersion, thanks to that. And so this I would use to get that gives you the aqueous depth itself. And in the calculation for the RIL, you need the back of the cornea to the front of the lens. This gives you the ACD. And of course, I need some other method to find the corneal thickness, ECT, and subtract it from the ACD to get the AD. So this is what I used for the CCT. The specular was also pretty good. And options, obviously he came to me because he wasn't happy with glasses. He could not possibly wear contact lenses in his sort of profession, very dusty, dirty environments. And laser treatment of the cornea wasn't an option, and not CLE. So only thing I could think of was phakic lens, but I told him that you will still have a residual power. I didn't think that. And this is, so I don't use the online calculator, because even if you fill it in, again, they may give you the options. So my counselors get this to me, fill it up, or one of my other doctors fills it up, get it checked, and then they come back with the options. And this is the online calculator for those who are interested. And this is the lens that we used. And these were custom made. So the right eye was a -29 diopter, the left eye was a -30 diopter. And these were spherical lenses. This is the surgery, as you can see, very short part of it. You've seen the more detailed one in the previous one. So I do it with viscoelastics, and this is a 2.8 incision actually, and very, very simple. I like this compared to ICL because of the loading. The loading in ICLs is harrowing. You're so worried that it's going to tear when you pull it from the front nozzle. And there it's done. I think those surgeries are probably done superior. I do my surgeries temporal, so I don't have to rotate my lens or anything at all. And this is the vault that I got, which is absolutely fine. 610 on one eye, 674 on the other side. It's again on an ASOCT. This is just about 2 weeks after the surgery. And the patient improved from 260 to about 624. But one thing that we went wrong is we actually overcorrected him. And he could have probably gone to 612, but it's so difficult getting a reflex. When you're doing retinoscopy, it's almost impossible, seeing that. I'm terrible at retinoscopy myself, but actually the people who were doing it, including pediatric ophthalmology, are very good at that. But then it was so impossible getting those shadows, seeing that. So actually they went for an overkill. Patient is still very happy. He's happy with his distant vision. But what's happened is he's become like a presbyope. So he doesn't wear his glasses, but then when he sees near, obviously we overcorrected him. So this is something that one has to really do it multiple times, probably on multiple days, so that one doesn't end up with this. So the results were fine, but probably we could have gone for a slightly less minus RIL. So in this case, of course, the improvement in the BCA was very stark, but normally I think it would improve by 2 or 3 lines. Safe for use in extremely high myopes also. Refraction retinoscopy is very challenging in these eyes, should be repeated on multiple occasions. Overcorrection like we had is a possibility. And patient satisfaction is of course extremely high. And it's, I think, the only safe option in these eyes. Thank you.
We'll go on to the next talk, which is clinical experience with RIL by Dr. Nishkant.
A very good afternoon to one and all present here.
We'll do it after the RIL session.
So I'm just going to share a few of my tips, tricks, and my experience which I've had with one of the best ICL lenses. So I do put star lenses and IPCL and RIL, and as sir said that the loading is much easier, just like how an phaco lens is put. I would say this is not some surgery which should be done by corneal surgeons. There is a myth that only anterior segment surgeons. I feel that any surgeon who's comfortable in placing a foldable phaco lens in the bag, this can be performed very easily. So just a small video to show how each one puts it differently. So the main thing is you load your own lenses. Always make sure that don't let the assistant load, because in theater I will say there is only one person to blame, that is the surgeon, not the assistant, not the trainer, or not the assisting doctor as well. Volume off. So knowing which side is anterior, it will be very easy because of the curvature. Fill it and always make sure that the hole is in the top right and bottom left. What happened? Why didn't go back? Yeah. So it should be in the top right and the bottom left. So try not to hold the center of the optic, always try to hold the flap edges. And once you place it under the microscope, just make sure that you see the loading position, which is very important. Each lens has its own way of loading and the positioning of each lenses, and this will be the end results, how it's there in both the eyes. It is very easy because we just have to place it in 0, 180, even being toric or spherical. So after loading it, the edges should not be near the flap, and when you look for it, see whether the lens moves easily before you go into the eye. So yes, it does go into a 2.8 incision very smoothly. So I always check not to overinflate the anterior chamber before injecting the lens. So while injecting, I'll have two important tips is don't directly push the lens completely inside. After you inject half the lens, you wait for the leading flaps to open up, like the wings of a butterfly. Once it opens up, you know that the lens possibility of it twisting or turning or flipping inside the eye is almost nil. So once that opens, then always I inject the leading half of the lens. And some people do have a doubt based on the material, is it possible to flip a lens inside without damaging the anterior capsule? Yes. With sufficient amount of visco below the lens, you can flip the lens if at all it is flipped the other way. Not necessarily to remove the lens completely and reload it and inject. So I go till the periphery because for me the flaps over there which is very stable. So till the periphery it is easier rather than pushing the lens too much. So I always go till the end and just hold only the flaps and tuck it inside. So the chances of me manipulating the lens or pushing the lens too much near the zonules and the sulcus is relatively yes. The need of surgical PI is depending upon based on surgeons, because few of my patients I actually do a YAG PI 1 week prior to the surgery because it's much more easier, the pigmentation are less, and once it starts bleeding while doing a surgical PI, I think it's going to be having a very tough time. You have to keep on washing, inject air, wait, tamponade the bleeding, and then again wash. So some of my patients I also do a preoperative PI with a YAG. So surgical PI or this thing is depending upon the surgeon's wish. So yes, I inject pilocarpine. Just wanted to share a few of my patients, and the power, I wouldn't say that it's used only for high power where it's either after 7 or after 8. I feel that any refractive patient who is not eligible for LASIK, this is definitely an option, because I have placed an RIL for the power of -4 for a person who wanted refractive correction but was not eligible to undergo LASIK in any way, and the patients are really happy. So this is one of the patient where the acceptance, you can see that it's improving only to 618 partial, but after around a week or so, you can see the drastic improvement in vision. I always check OU vision. I do not check independently OD and OS. I would say that that is also one of the tip which I learned in one of the conference, that do not check for the vision after a week's time individually, because we know that we have the stereopsis and the patient might be high in one power and low in the other power, and they do increase reading few lines as well. So this was with the cylinder where I used the toric, and using the toric, the best thing is I mark the patient in the slit lamp. I don't do it on the table. So slit lamp, I just make the 0-180, sit temporarily, inject it, and place the two, you saw the marking at 0-180. You need not dial these lenses to the axis. That's the best in these lenses. So this patient, actually the improvement was only around 624 and 612. I think might be due to amblyopia. So the patient was very, they also wanted to say that I want to check individually. So for them I checked. But then when I actually gave OU vision of 6.9, I said that, look, it depends upon what you want to do. You want to see much more clearer, use both your eyes. If you keep comparing your eyes, you are going to feel depressed that you are not reading much of lines. So this is also a power of around 16 and 14. So these minimum astigmatism will be compensated because of placement inside the eye. So they will actually need only spherical lenses. But even with 6.9 and 6.12 vision, you can see even with contact lens, their vision is not improving as much. But with RIL, you can see that the vision finally improves to 6.6. So a few tips is like inject the lens slowly, inject the first half inside, wait for it to open up before you inject the other half, and then start injecting the leading half. So the data, we have done around 32 eyes. The vaulting is pretty good for around 400 to 600 microns in around 26 eyes. And these 6 eyes, the patient was little more myopic, where they had a little more bigger anterior chamber. Intraocular pressure was actually good in all the patients. I mean, initially, because of either retained visco, I had to use anti-glaucoma for a week or 10 days, but after that, when you recheck, they are perfectly fine if your white to white measurement is taken properly. I do it with the digital caliper under the microscope or in the slit lamp with a loop, but please make sure that don't depend on either machines. I mean, ObsCan do give, Cirrus do give, Pentacam does give, but nothing is as accurate as a white to white measurement with the digital caliper. The lens status, we have had follow-up for around 4 to 5 years. It's pretty clear. And there was one patient who was operated by someone else around 10-15 years back who developed cataract. And explanting it, it was as easy as explanting any other ICL, where the incision had to be only 2.8. That was also a doubt whether we have to extend it to around 3 or 4. No, it was just 2.8. The lens was held hand over hand technique. Just try to get the first grip initially very tight with the tooth forceps. And once one part comes out near the section, you use the hand over hand technique and try to remove it. And then yes, the phaco was done and the lens was placed in the bag as well. So there was almost around 28 eyes with vision 6 and around 2 with 6.9 and 2 less than 6.9 who was ambelopic. Thank you.
Thank you. We'll move on to the myopin clinical outcomes and treatment protocol. And in the meantime, I'll ask Dr. Ananda Babu to give a prize, courtesy Appa.
Can we have the auditorium lights on? Just for a second, can you switch on the auditorium light? Dr. Shashikant Kulash. Dr. Shashikant Kulash is here in the hall. Okay, you can pick one more. Dr. Gomadi Nayagam. Dr. S. Gomadi Nayagam. Please come over to the dais for a second. Can you come over to the dais for a second? Request our director, Dr. Anand Babu, to give a small gift from Appasamy. It's a trabeculectomy 2-mirror lens and the myopin. Lights off, please. We have 2 more gifts to go, so at the end of the session we'll be doing it.
So we'll move now on to hoping that sometime in our future we will be able to make these RILs redundant by preventing patients from reaching such high myopias. So this part would be a set of hopeful thinking on our part that we may be able to catch them younger and be able to prevent this from happening. So first question is for us to know that is it such a big problem? And while in India we for 2 possible cases have not till yet been concentrating on it. One, because we are actually not thinking about it so much, and 2, probably it is still not so much as we expect it or see it in the East Asian countries. But there was this study which was really an eye-opening study which was published by the Brian Holden group in ophthalmology, which talked about the global prevalence of myopia and high myopia and the temporal trends from 2000 to 2050. So it was a predictive trend analysis that they made, and they said that in 2000, about 22% of the world's population was myopic and 2.7% was high myopes. But by 2050, nearly 50% of the world's population will be myopic, and nearly 10% of them would be high myopes. So besides the RILs, they would really be requiring a lot more intervention, particularly related to the retina. So The question is that is it really a problem for us in India? Because till now, really, except in the past a year or so, myopia was the only thought process of an ophthalmic surgeon was that it's going to give me some more money. But now we are really concerned that we should hopefully not go the way of East Asia. What we could see was that while this was one of our studies which we had done, which was a prevalence of myopia study in a school children, which was published in PLOS One first, and we found a 13.1% prevalence in school children. And when we compared it to the close to 50% or 80% in some East Asian nations, we thought it's not such a big deal. But when we looked at the incidence, we followed up the same group of children of about 10,000, and we found that the cumulative incidence was about 3.3%. But again, it didn't look so, so devastating compared to 4 to 14% in some East Asian countries. So, is it really a cause for concern? But again, if we use some projection, we realize that if there was an incidence of 3.3% cumulative over the next decade, we would expect that more than 30% of our children would actually be myopes. So if there is a 3.3% incidence, you'll know that every year this is going to progressively increase. So we are expecting that things will start getting worse. So the importance is to realize that we need to do something about it. The second thing was that in the same place where we had done this survey, almost more than 10 years ago, a similar survey was done by RP Center in that same place, and we found a 7.1% prevalence. So you can see that it was nearly a jump of a doubling of the prevalence in the same area over about a decade. So two things, it is happening in India, and we are not genetically kind of immune to it. This was a study which was done on first generation, second generation Indians, and who had immigrated to Singapore, and the first generation had about 12% of myopia, and the second generation immigrants or the children of these immigrants had almost 28%. So again, as a race, we are not really immune to this. There are major problems besides the learning ability, retardation, doing poorly in school, sports, and others, suffering of injuries. There is the long-term problem of strabismus, amblyopia, and pathological myopia. The other problem is that although the intervention, especially in children, looks very innocuous in the form of spectacles, but a previous study had said that the cost of just spectacles in the US was close to $4.6 billion per year, and you can think what cost it would be in India. So based on the studies and the work that has been going on, and there is a lot of interest in this, particularly in East Asia, where we are seeing close to an epidemic of myopia, there were some major risk factors which we also found out in the children we had evaluated. So one was a very surprising thing. It was a school type. So we had actually taken two groups, both government schools and private schools, and unfortunately we found our children who were studying in the private public schools, as we would call it, had the prevalence was more than double than that of the government schools. It was about 4 to 5% in the government schools, and it was more than 20% in the private schools. So school type essentially was important. Family history, of course, was important. Socioeconomic status kind of gelled with the school type actually, because they were seen far more in the affluent group of children, those who did a lot of reading, writing, and video games. And outdoor activity, which has been consistently now being seen, was protective. I mean, found that children who spent about 2 hours a day outdoors and not necessarily playing any sports or games were protected from the progression of myopia. So parental myopia, extremely important as a risk factor for development and progression of myopia. And demographically, the other thing we found was that girls were more likely, at least in our group, and a lot of studies have actually found girls to be more likely to develop and progress myopia. And with higher education, the prevalence is significantly increasing. One of the thoughts behind, especially in East Asia and the urban epidemic that is happening, is that they are living in constricted spaces. There is no zero horizon, there is no infinity to see and the eye to actually relax. And the constant indoor activity and close work increases the risk of myopia. So it's the use of accommodation which is one of the hypotheses which is considered to be responsible for this. The other is the light dopamine hypothesis, that going outdoors actually resulting in the release of dopamine on exposure to light limits or manages the progression of the elongation, the axial elongation of the eye. So management can be spectacles, contact lenses, progressive ad lenses, orthokeratology. So I'll just run you a few of the basic ideas for management, and of course the pharmacological modulation will be in the following conversation. So there are a lot of spectacles. So we know that unifocal spectacles do not help, but there are two kinds of spectacles that have been evaluated. One are the progressive ad lenses. We know that these myopic children have an accommodative lag, so they are having difficulty in near vision. There is a little difficulty in near vision. Because of that, possibly the eyes are growing longer. That's a stimulus. So there is a blur when they're looking for near, and that causes axial elongation, resulting in the myopia from developing. So an accommodative lag exists in these children, and therefore by giving progressive additional lenses, there is a hypothesis that we may actually be able to prevent the myopia from happening. The other thing is the other concept built was a peripheral additional lenses. So it was current monofocal spectacles actually correct you for central vision, but as you go to the periphery, there is a hyperopic defocus. The globe is not a perfect sphere, so there is a peripheral hyperopic defocus. Again, is considered to be a reason for the eye to elongate for the defocus and correct for that. So therefore, peripheral additional lenses which create a peripheral myopic kind of a refractive error that prevents the elongation. So again, these are lenses that are under trial, not only as spectacles but also contact lenses, and a fair amount of improvement is seen in this. The others are bifocal prismatic additional lenses. So besides that, some children who have oculomotor anomalies like esophorias or exophorias are also seen to progress rapidly in their myopia. So some amount of prismatic correction along with the bifocals has been seen to significantly reduce myopic progression. Soft contact lenses, of course, just unifocal soft contact lenses are not found to be useful, but bifocal contact lenses and of course orthokeratology, which I'll be talking about. So soft multifocal contact lenses is the other thing, which is again showing that there is a significant reduction in the progression of myopia. Orthokeratology is something which initially came just to correct myopia, but over follow-up it was found that it actually prevented the axial elongation. Now, how it actually did it or just prevented the cornea also from steepening up, we are not very clear, but it is again known that the moment you stop orthokeratology, the rebound occurs and the eye again starts elongating and getting myopia. Pharmacologically, any other form of medication has been tried, like timolol, pyrazipine, but the only drug really to be effective is atropine, and these are this, and along with a couple of series of some wonderful trials done from Singapore have led us to the concept that probably low-dose atropine will help, and my subsequent speaker, Dr. Lipika, would be talking about it a little more in detail. The other thing that is important is the role of environment, and we know that outdoor activity significantly decreases. And these are all the various summarizing, but I'll just show you in this table. You will see basically myopia progression, what works and what does not. So ones that are higher up on this graph are more likely to be effective. So most effective currently is atropine, orthokeratology while you're doing it, prismatic bifocal lenses, and progressive additional lenses. So these are currently known to be very beneficial. Time spent outdoors is still under study, but adequate evidence has been piled that there is adequate evidence that outdoor activity is definitely protective, and this has been now substantiated by a lot of cross-sectional studies. There are 2 or 3 interventional studies where outdoor activity is being tested, including one which we are doing in Delhi, but of course an absolute impact per hour or study is yet to be established. So where are we? The key is increase awareness about myopia in the next generation. We are sure that outdoor activity works. Atropine, how effective it is in our Indian population, we really need to accumulate data and understand its effect, particularly the long-term effect on the eye and the growth of the child. We know about peripheral additional lenses as well as ortho-K. So we are still looking at and evaluating and understanding myopic progression in children and how we can prevent progression and halt it so that they do not become high myopes. Thank you.
Dr. Lipika Roy on uses of atropine 0.1%. Today we'll have.
Good afternoon, everyone. Before I start my talk, may I just have a very quick question? How many of you sitting in the room are using 0.01% atropine? Or, I mean, we have, a couple of companies who are supplying it. One of the things which we use is Myopia, any of this sort. Any one of you here using 0.01% atropine in their regular practice? Okay, only hardly few hands we see. So with this, I'll just move forward. Okay, I think we have heard a lot about the RILs and also what Dr. Rohit mentioned in his talk, that we all agree the consequences of high myopia. So if we just see that how the increase in the ocular diseases, it increases as the myopia increases. If you just see the way the odds ratio increases, with the increases myopia, it's really, I mean, something we need to look at it. If you see anybody having a myopia of -5 to -6, the chances for the maculopathy almost increases to 40 times. So it's a very high number. And as we move forward on this, that amount of resources spent on the treatment, obviously, it also multiplies. Atropine background. So it's a non-specific muscarinic antagonist. Now, what is the mechanism of action? It is still debatable. There was an old school of thought that it inhibits accommodation, but according to the new hypothesis, atropine may upregulate or downregulate the muscarinic receptors on retina and sclera, which in turn affect remodeling of sclera. But as I said, it is still a question mark. How does it work? And let's see what the trials on 0.01% myopin or atropine have shown. Now, there have been two basic trials which have kind of changed the paradigm in which we have started using low-dose atropine. One of them was ATOM-1 study, which was done in Singapore. It's the atropine treatment for myopia trials, which was a double-masked randomized controlled trial with almost 400 eyes, and atropine 1% was evaluated against the placebo. Then there was an ATOM-2, which assessed the effect of different doses. It was also a RCT double-masked trial with 44 number of patients, and it evaluated the different doses, 0.5 versus 0.1 versus 0.01%. Now let's see what were the key takeaways from the studies. It showed that all these studies were showing the dose-related response. There was almost the myopia, it slowed down by 80% in atropine 1% concentration, 75% in 0.5, followed by 70% in 0.1, and 60% in 0.01 in 24 months. There was a less rebound in the low dose. So what was the thing? As you approach towards the ear, the atropine or the drops with the highest concentration obviously would show the maximum efficacy. But as the drops were stopped, the higher the concentration, the highest was the rebound, which actually obviously we are not looking forward as we are treating the patients. There was a change in spherical equivalent of almost -1.4 diopter, which was significantly less in 0.01% in 5 years. Axial length progression was slightly less with 0.01. It was around 0.75 mm over 5 years. But there were significantly less side effects and no impact on quality of life with 0.01%, because you can imagine if you are putting 1% atropine, the child is always dilated, you end up using bifocal, so there were lots of other things that come with it. And it was easy to administer, 0.01 dosage, it was only once daily. Now from the evidence to the real practice, whom to treat and when to treat? I think that's the main question that generally comes up when you are in a real clinical setting. Generally, we treat 6 to 13 years of the children with history of myopia progression. This is important. We need to see the two subsequent readings. Either there would have been increase in 0.5 diopters in 6 months or annually. More than 13 years if history of progression, or if there is a history of high myopia in family. For less than 6 years children, we need to have a watch out, especially if the parents are high myopic, and counsel parents subsequently for the treatment, because as you would know that this treatment is not for a year or so. You really have to monitor the patients minimum for 2 years, then you have to again monitor for next year for a rebound. And 0.01% dosage is given once daily at night. Now the next thing is duration and the follow-up of the treatment. Minimum 1 year will be required to understand how the whole treatment is going and how the response is coming up. In our general practice, we generally tend to call the patients in 5 to 6 months, or if much better in 3 to 4 months during when we start the atropine first time. If rate of progression, it slows down to 0.5 diopters per annum or in 6 months, and it continues, the child is on continuation for 6 more months to maintain the stability of the refraction. Appropriate duration of the treatment, as I said, and which has been done in all the basic trials of ATOM 1 and ATOM 2, is 2 years. Follow-up after stopping the treatment is very, very critical, because still, as we'll discuss further, there are many school of thoughts how the follow-up should be done, but in an ideal setting, you should be following up the child till the kid is 13 to 14 years. First follow-up post-treatment, 6 months, followed by an yearly follow-up is what we would like to recommend. If myopia progresses after 6-month follow-up, restart atropine 0.01%. Now, these are some of the cycloplegic readings which generally can help us to watch out and just be on guard in the event you want to counsel the parents, or there is an history, accompanied history of high myopia or high risk candidates whose parents would be having myopia or family history. Age less than 6, if your readings are less than plus 0.75 diopters. In grade 2, between 7 to 8 if it is plus 0.5, and by 9 or 10 if less than plus 0.25, but I think by 7 or 8 you would actually come to know how the child is progressing. Now this is the chart which we follow at our clinic at Center for Vision in Chennai. Generally we do have a selection criteria this is followed standardized across all our clinics. Any child 6 to 13 years, more than or equal to 2 diopters, and there is an increase of 0.5 diopters annually with no history of either amblyopia, squint or any other ocular pathology. The patient is sent to the myopia clinic where we have the counselors, and they do the counseling for the suite program, which I'll discuss what it is, and they follow the protocol. Once the child is into the myopia clinic, each child goes through the biometry, and if the astigmatism is more than 1.5 diopters, or if 2 or more and we see it increasing, we do prefer the topo as well, and the cyclorefraction, which is a must. Then the child is put on atropine 0.01%, follow-up for 6 months. Each follow-up you need to have a refraction. It would be ideal if you have the same set of people doing that, and if there you document an increase, then go for a cyclorefraction, and we follow up, next follow-up is at 12 months, which means the next 6 months. These are some of the eye exercises we also recommend, and I would tell you why is it important. And there is a very lovely video which is in BBC at CNN, which has been, essentially came from the Singapore Eye Center, of about the use of atropine 0.01%, which just helps the patients to go through it and understand what we are talking about. So this is a suite protocol which we do, and explain it to the parents to give the right fit of the spectacles, wean off the gadgets, go for eye exercise and nutrition. Though we have heard the talk, there's still the role to play, but I think healthy habits still go a long way. eye drops, which is essentially atropine 0.01%, which we are using myopin. It is told about the studies and all regarding the progression, and training or the teaching of the parents about the consequences of the high myopia and how the atropine 0.01% works, or to give them more confidence, showing them the videos and all, which would be very important once you have in the private setting, and the parents would ask you very lots of questions that why they should be putting their child on the eye drops. Now this is the protocol we follow before starting the atropine. Where every child goes through the biometry so that we have the proper measurements of the axial length, which we repeat after every 2 years or after the finish of the treatment. This is the follow-up schedule which we follow once the child is on 12 months for the atropine. We repeat biometry and the cyclorefraction here. If there is no progress, means the refraction stabilizes and we don't see anything, we follow the taper regime, which is essentially we reduce the atropine frequency to 3 times a week because of the high rebound effect. That's why we've put it for 3 times in a week, generally Monday, Wednesdays and Fridays, and patient is asked to come back 6 months. And if there is no change again in the refraction or stable, we stop atropine and keep on following yearly after. If the child is still increasing by 0.5 diopters, we continue atropine 0.01%, but we do repeat refraction and biometry, which becomes very critical to see how the axial length is also showing off. And if the child again comes to it stabilizes, we follow the taper regime. Similarly, for if you have 0.25 diopter increase, we still continue atropine for 6 months, but we don't repeat the biometry. And if the refraction is stable, we move to the taper regime. So the real situations which come to us in clinical practice, if the child is less than 5 years or more than 13 years, and if the progression is more than 0.5 diopters, which is documented on 2 refractive readings with an interval of 5 months, we do start the child on 0.01%. Sorry, it's not 0.1. If there is a family history of moderate to high myopia, we do watch 6 months, and the child is started on 0.01% if there is increase in 0.5 diopters. If the astigmatism is stable, these are the tricky cases, but increase sphere component, then we do start on 0.01% if spherical progression is noted. This you have to see according to the case wise, so that's why we have not put it in the protocol. If any missed doses, we ask the patients to resume once daily dose as soon as possible. Now, what are the new horizons? There are lots of unanswered questions.
Can we conclude, because the next speakers are also here now.
So we use atropine in pre-myopic cases, optimal dosing, management strategy in suboptimal responders. Atropine needs to be evaluated, treatment strategy, and the target population. So the conclusion, atropine 0.01% appears to offer an appropriate risk-benefit ratio with no clinically significant visual side effects, and it's balanced against a reasonable and clinical significant 60% reduction in myopia progression. So I think with this, I would like to thank you.
Thank you for staying, and we have 2 gifts to give with sponsored by Appaswamy. Dr. Anand Babu, I'll request you to please pick up the names of 2 people. So what do we have? We have gonio fundus lens and a 3 mirror and a phone. Yes. So this is Dr. K. Madhukar, if he's here. K. Madhukar, please. One more. Dr. Narendra Nath. Dr. Narendra Nath is here? No, one more we picked up. Dr. Ashok Thadani.